tonight. We're going to have 3 speakers tonight. Our chair for tonight's meeting is going to be Chamley, so without further ado, bring him up to introduce our speakers.
Good evening, all. It's going to be a long meeting, so I'm going to be very short. Our first speaker is Dr. Krishan Bag, consultant urologist at San Fernando General Hospital. I understand your specialty is in oncology. Yes. Oncological side of kidney stones. Can you please welcome Dr. Krishan?
All right. Thank you. I'd like to thank the TTM South Protective Branch for having me here. And to clarify that, unfortunately, in Trinidad and Tobago, as a urologist, you need to know how to treat stone disease, right? Because that's the mainstay of urology in Trinidad, as well as prostate cancer. But we'll leave that for the next week. All right. Let's get the first slide. Right, so we're just going to begin by just refreshing ourselves with the anatomy of the urinary tract. Right? So most of us are familiar with where the kidneys are planted to peritoneum. It's covered by ribs 11 to 12, as well as the psoas muscle. And it's covered anteriorly by the abdominal contents. Okay. We're going to talk about urinary tract calculi, not also kidney calculi, but urinary tract calculi. Because once a kidney stone develops in the kidney, it alters the whole urine and moves into the bladder and then very out. Most studies have shown that 80% of the stones that most of us form are less than 7 millimeters. Right? And once it's less than 7 millimeters, it usually comes out with or without herbal treatment. As most of us know that when a patient comes to you, by the time they come to you, they already tried a whole host of herbal medication. Right? And I try to tell patients, it doesn't matter if you take herbal medications or water, most of the time you're going to pass that stone. Okay? Right? So I'm just going to go on to the pathogenesis of stone formation. Right? These are just big theories stating that basically we don't know what is basic why we form stones. Right? There are 3 theories that we propose forward. The nucleation theory is that what happens is that the urine is supersaturated. We get a crystal forming in the supersaturated urine, and then from that, more and more crystals form. The next theory is a stone matrix theory, in that multiple small little calculi are formed, and then they coalesce together to form a stone. Right? And then there's inhibitor of crystallization theory, in that there are certain substances in the urine itself that prevent stone formation, and some of us there's a genetic failure in one of those things, and we get stone formation. But most of us think that it's a combination of all of these theories, right? That actually report. Okay, let's move on. Right. So the prevalence of kidney stones in Trinidad and Tobago, right? Data is lacking, sadly lacking in Trinidad. And I know most of you doctors here would have treated someone with kidney stones, or you have some family member who have had stones. Recently, we have been treating more and more doctors with stones. All right. Now, in the US, in the 1970s, 1 in 51 persons, right, they were found to have stones. And that has tripled presently to 1 in 11. Right? In our clinic in San Fernando General Hospital, we started a database in compiling patients who come in with stone-related disorders, whether it be colic, previous history of family stones or stones, but that is incomplete, and we only started it in 2013. The Osteoarthritis database of patients in Trinidad or in our region is that most of us in the department, they are not compliant in filling out reports. Because I can tell you when my unit started in 2013, right, I started collecting all the new patients that came to me. To date, we have 437 patients in just one unit. It's just stone-related disease. 56% of them are stone-related illnesses or stone-related issues. Now that's only one unit. If we combine the other three units, I'm sure it will be more than this. And this is only one region, right? And imagine if we have 4 other regions, right? So I think that the patient load that coming to us as new patients, most of it is kidney stones, right? Rest we have other issues like prostate disease, urinary continence, and such. But most of my patients right now are stone related. Okay, and we started this database, but we are having some issues with young doctors trying to pull it out. Right, so we are having some issues, but hopefully in the next couple of years, we'll actually tell you what's happening in Southwest. Right. Next slide. Now, with that 56, now we started, although the data is incomplete and I'm just telling you what's happening in one unit, right? What I did is that I started to look at the age distribution, by the age, gender, or racial differences, right? In San Fernando in one unit, right? The age difference, the age is similar to international figures, is that we have a peak incidence between age 35 to 60. Gender, male to female, is 1.3 to 1, right? And this is closer to international figures also. But I think, just by looking at some of my data, I think it's the male to female ratio is getting to be nearly 1 to 1, right? The racial differences, you can see almost between Indo and Afro-Trinidadians, it is more 4 to 1, right? There's no, with the racial differences, if you look at the international figures, most of them compare Caucasians, either patients in the subcontinent of India or even Europe, but we don't have racial differences in Trinidad. But at least I'm trying to at least see what we have in Trinidad. And just from our new patient database, you can at least see there's a 4 to 1 difference in the racial the differences between the Indo to Afro Trinidad. Okay, next slide. Okay, now risk factors. Again, I look at the risk factors in most of my new patients. At least 30% of our patients, right, have a family history of stones. Either their grandfather, their father, their mom, or some uncle usually have a kidney stone. Right? Environmental risk factors. We live in a hot country, right? The dry season. I think the dry season now is extending from December straight on to December, because I think there's no more wet season again. If there's a couple of days for rain, well, all well and good. So right now, to me, I think there's an increase in the amount of people that we see with stone-related disorder, right? Also, patients who work on the outside, right? The laborers, the policemen, people who work in as cooks, right? They have also an increased incident of stone formation, right? Systemic risk factors, and we also see a rise in patients who are diabetics and who are obese. They are presenting now with uric acid stones, right? And the reason for uric acid stones because there is a deficiency, or sorry, principal in there, but there's a hyperinsulinemia, right? As well as insulin resistance that causes adverse change in urinary composition. What happens here is that there is a defect in the word that they use is the aminogenesis that's happening in the kidney, which causes a decrease in the pH of the kidney. Once there's a decrease in the pH of the kidney, that's a good environment for stone formation, especially uric acid stones. And I can tell you a fact that we have been seeing most of our patients who are coming to the hospital and they do a screen or ultrasound or CT scan. The diabetics and the obese patients, they have some symptomatic and some unsymptomatic stones, right? And unfortunately, you cannot pick up those things in ordinary X-rays. Most of the time, they have to pick them up in CT scans. Other risk factors, thyroid disease and gastrointestinal disorders, right, such as inflammatory bowel disease and bariatric surgery. With respect to bariatric surgery, I spoke to Dr. Dan, was the largest series of bariatric patients in that, but he hasn't seen any increase in stone in that population, right? But he said his data is still out there and it's still collected. It's only about 4 to 5 years young, so you know they still have a long way to go, right? Next slide. Now coming on to the clinical features, most of us know that when we have stones, either you have severe renal colic or severe uterine colic, which is either severe loin pain or loin to groin pain. Most of the time it is accompanied by either vomiting or nausea. And when you do your urinalysis, you usually have microscopic hematuria. Patients who have chronic stones or who always present with stones, right, or have a family history or they have some issues, right, they tend to have associated little or no pain, and they usually present with either renal dysfunction, anemia, weight loss, and most of the times they have some kind of infection in the age. Okay, next slide. All right, investigations. When we see most of our patients, well, stone patients, they usually come to us with a urinalysis. Most of them have microscopic hematuria, or sometimes some nitrites are usually high also, so they have a concurrent infection. We do routine blood tests, right? Usually hematological, which is a CBC, biochemical, which is renal function, uric acid, and calcium. The reason that we do calcium is just to rule out to see if the calcium is high, then move on to do our parathyroid, right? Because patients who are, as we said before, they are one of the risk factors for forming stones. The current investigation, the current gold standard, is a non-contrast CT KUB, right? Anywhere in the world you go now with any abdominal pain, you get a non-contrast CT KUB, right? But in our setting in San Fernando, I mean, over the last 3 to 4 months, most of our patients that present us in the emergency department, they come with a non-contrast CT KUB, which is all well and good. But sometimes the scanner is down, so we have to revert back to the usual X-ray, or the X-ray KUB, or the ultrasound KUB. The problem with the X-ray KUB is that some of the stones are radiolucent, right? And you can't see them, right? And these patients are coming with severe pain. So then you say, well, it is severe pain, maybe you want to do an ultrasound. And the ultrasound could only pick up the kidney and maybe what's in the blood, but not in the ureter, right? So that's a problem with the ultrasound. But in most centers now, what they're doing, if there's no scanners available, CT scanners, they just do a screening ultrasound to see if there's any hydronephrosis. And then maybe book the patient at a later date for elective CPK. I know most of us, when we were, well, for me, when I was now starting off in urology, the IVU was done on a regular occasion, but now it's just really done for special occasions only, right? Especially when you plan surgery to do all of the all medical stuff, right? Now, recently, our guidelines states that if it's really see a patient who is a first-time stone former, right? They think that we should now start doing metabolic evaluations. Before, metabolic evaluations is to be only for recurrent stone forms. The metabolic evaluation is usually the blood test that you see there, as well as the 24-hour urine, right? Which is the volume, the pH, the calcium, phosphorus, citrate, and oxalate. Now, unfortunately, most of these tests are not available. The 24-hour urine is not available in San Fernando. And if you're going to send a patient, you have to warn them that could be rather expensive, right? The 24 urine outside could be anywhere between $2,500 to $3,000, right? So you have to be very careful if you're going to advise a patient to do a metabolic evaluation, especially for first-time stone former. Maybe if it's a second, if it's a recurrent stone former, you could maybe advise them to do that, right? But in hospital right now, most of the time we tell patients, you know, if you're going to do a 24 urine, it's a rather expensive test. Right? Most of them usually do it if they come back with time.
What are we doing at those tests and how?
Huh? Sorry?
What do you do?
Right, so we check in for the volume of it, pH, right? Because if there's a low pH, which means that it's a greater likelihood that he may form a stone, because patients have a low pH. It's a very good medium for stone formation. The volume, what you check is that if the patient is not drinking enough, you will actually tell the patient, well, you know, if your volume is just only 600, you should be actually up to about 2,000, right? ml, right? Phosphorus, if it's spilling over into the urine, if there is a greater, I can't remember the actual figure, you might want to increase, you might make his diet in that respect. The citrate, right, is one of those substances in the urine, soluble compounds, right, with stones. And if there is a low citrate, maybe you'll advise the patient, maybe you want to start some whatever have you to boost up the citrate. Oxalates, well, we have, lethal food right here. Most of the food here that we eat is not very high in oxalates. All right, so if you have if a host of oxalates is spilled over in the urine, advise the patient in that. Right, but usually when our advice to most patients, right, we tell them about the oxalate, what foods contain oxalates, and help prevent other stone formation, maybe increase the citrate. We live in a tropical country, it's to get aligned. Any other? Right, but so that's the reason that we ask them to be 24 years, just to advise them how to take their diet. Right? Next slide. Right, treatment options. Treatment options over the last can change, right? And all depends on the stone size and where the stone is situated, the kidney or the ureter. Now, stones less than 7 millimeters, and why 7 millimeters is that the diameter of the ureter is about 5 to 7 millimeters, right? The average diameter. And if the stone is 7 millimeters, there's a good chance, like I said before, 2% of patients, once it's less than 7 millimeters, you're going to pass it. You're going to pass it. All right? Now, if it's in the kidney, and it's 7 millimeters and it's not causing any issues, right? You tell the patient, you advise them that conservative management may be the way to go. Advise them on increasing his fluids, maybe put in some citrates or giving them some antispasmodics or to see if he can pass out on his own. Right? Before, even if the patient was non-symptomatic, you go and do something about it. But now, the guidelines dictate that once it's less than 7 millimeters and the patient is asymptomatic, you should advise the patient on maybe a conservative approach to this. Right? If it's in the ureter, obviously, those of us who experience uterine colic, or who have patients who have uterine colic, you know these patients, they're in severe pain, right? You usually have, and it's accompanied by either hydronephrosis or hyperureter. And recently, over the last, I would say 8 years, our guidelines dictate that these patients, once his stones is less than 7 millimeters, advise them again, right? That maybe that they will pass the stone, and yes, we will give them some medications to help them pass it. Now, over the last 3 years, our guidelines came up with a expression, medical expulsion therapy. Once a patient has a stone less than 7 millimeters, right? Once their medication is once their pain is controlled by NSAIDs, right? You can send them home with alpha blockers, right? What the alpha blockers do, they help relax the ureter. Also antispasmodics. Antispasmodics, when a stone is coming down, they tend to cut the ureter and the ureter goes into spasm. So the antispasmodics help with the spasm. The NSAIDs, again, they are differently. Yes, most NSAIDs are very good painkillers, but they're also good for the swelling in around that stone area. Alright, so once a patient he agrees to this and he said, well, most are really advising that most people usually pass their stones. They usually agree to medical expulsion therapy, and we see them back in our clinic and we monitor their progress by either ordinary X-ray or ultrasound. Right? Depending on if you can see the stone or not. Next slide. Right. Stones greater than 7 millimeters and that are right? In the kidney, right, we have 2 treatment options now. One is non-invasive and invasive. The non-invasive is extracorporeal shockwave lithotripsy, right? We localize the stone via X-rays or ultrasounds, and then we use shockwave to match up the stones. This therapy is available both privately and publicly. We advise patients if they want to go that direction, we usually go that direction with them. But we also explain to them that if this stone is very hard, after the first and second treatment, they may need to progress to something else, okay, which is something a little more invasive. As well, or extracorporeal shockwave lithotripsy is good for stones that are less than 2 centimeters in the upper and mid pole, and good for stones that are less than 1 centimeter in the lower pole. Okay, if it's greater than that, the stone clearance rate is a little bit lower. Invasive methods is percutaneous nephrolithotomy and open lithotomy. Nephrolithotomy. The stones greater than 1 centimeter. I know most of you all know more about open nephrolithotomy, but over the last 2 to 3 years, in our department, we are going more the percutaneous route. Right? The reason being is that most patients, they are complaining about the scars, they get in incisional hernias, and they always come back with this chronic pain with the open nephrolithotomy. So over the last 2 to 3 years, most of the consultants, we are going in this direction, percutaneous route, where we puncture the kidney via the Saldinger route, right? And then we dilate that puncture site up to about 35, which is 1 centimeter, and via different NG sources, we go and mash up the stones. Patient stays about 1 to 2 days in hospital, and then they are back out to work within the next week or so, right? Don't get much issues, right? I just put this word here, flexible uterine laparoscopy. That's also invasive, but it's rather expensive, right? This is for stones that are 7 millimeters or less, and it's giving the patients pain, or they're very uncomfortable with it, and both the invasive and non-invasive methods. Right, the minimally invasive method is not working. We just move up into the kidney and we laser the streak. Next slide. Right, in the ureter, the treatment options now is mostly minimally invasive. Right. Before, after about 3 or 4 years ago, most of the time we used to do either open or laparoscopic, which is a little large, rather large cut. But now, I haven't done open or laparoscopic over the last 2 3 years. So most of the time, I do endoscopic via the ureteroscope using either laser, pneumatic, or ultrasound ultrasound. Okay, and that's this is like closed-hole treatment. Right? Most of you guys who send your patients to us in the urology departments and have stones in the ureter, most of them get this. Very rarely somebody will get a cut. Next slide. Right, roll of stents. I mean, most of you who have stents, you have patients who have stents, or relatives who have stents, and it's a real issue. Right, but stents now are used just to drain the obstructed kidney. As a stones are 7 millimeters or more than ureter, and the patient is still getting symptoms, right? So we use it now to drain the obstructed kidney, and most of the time they help with their pain. Also, it helps to dilate the ureter and helps to facilitate the stool to come down the ureter. And also, if it's a big stone in the ureter or the kidney, it helps to prevent what we call Steinstrasse, and also help us to do further procedures if it is required. Next slide. Now, stone prevention. And come back to Dr. Chan. She will be over 24. So when we do 24, usually we advise patients on why we are doing to make sure they don't get back a stone. Most stone formers, for patients who have stones, first-time stone formers, we always tell them there's a 50% chance of forming the next stone in 5 years' time. Many studies are showing that. Right? This is not what we tell our patients. Right? So what we tell patients is we live in a hot country. If you have a high oxalate count in your urine, maybe you want to tailor-make your diet in such a way that it decreases your oxalates. Right? Also have a moderate calcium intake. Now, most of us were taught that if you have stones, to stop calcium and calcium products. But 10 years ago, a gentleman did a study with 20,000 patients. Right? With 20,000 patients, he gave them a high calcium diet, a low calcium diet, and a normal calcium diet. And what we found in patients who obviously the high calcium diet will form stones, patients with low calcium diet, but we didn't expose the patient with high calcium diet. So now we tell them, and the patients that form the least amount of stones is patient with normal calcium diet. So now we tell patients everything in moderation with the cheese and chocolates and whatever else, right? Don't overdo it. Citrates. Citrates, like I told you before, they form soluble compounds, release stone crystals, right? And what we advise patients is, because we live in a hot country, in a tropical country, we get limes and lemons. You can buy it or you can get it in the grocery. People in temperate countries, they give them tablets. Some people have potassium citrate. Some of us who are around my time will know about Wisconsin, which is a solution of potassium and citrate, right? I gave it to patient, but that again is bitter, so I just advise them on just taking some limes or lemons and diluting it. Right? And if you are dehydrated, make sure you drink as much water as you can, right? Keep up with your fluids. Okay, and that's talk for stones. Stone disease. Okay. Many questions? For
I have about 3 or 4.
yes.
Yesterday we were told that 90% of stones have calcium in them. Is that still hold?
Yeah, that's it. Most of those stones have calcium.
Some of our consultants still use diuretics in the management of stone. Does that still hold?
Yes, but it's only some particular stones. Right? That's probably what after you must do a 24-hour evaluation on your patient first, right? And see if the patient now is if there's a low citrate count, right? Citrate count, right? And you look boost up. Sometimes the thiazide diuretics they prevent the citrate from spilling over into the urine, right? Yes, but it is yes, it's there.
All right. NSAIDs. No NSAIDs for skin cancer. Why are we encouraging NSAIDs as an analgesic in the management of stones?
Right. So the NSAID is doing these, right? 3 to 4 days, right? Just for the swelling to go down. I don't give it for more than 5 days. Right? Because if a patient comes to you right, in hospital, right, you give them an injection, right? Whether it be tramadol,
the ureter at a level. What happens if the ureter below that? The size doesn't change. So if you're doing stenting, what happens to the distal to the stenting? The stone cell has to pass on that.
right. So distal to the stenting, what happens? It makes that natural narrowing, which is called the VOJ, makes it a bit incompetent. Right? Remember, there's a VOJ, that's a natural narrowing. So what happens is it makes that valve incompetent. Right? And what happens is stone now could just come out.
And just 2 other sections. Juicing, which is very, very common nowadays, increases the oxalate content.
Yes.
So we should not
yes.
not to juice too much. And secondly, too much vitamin C. The end product of vitamin C is the citric toxic and can produce kidney
right.
stone.
So high concentration, high doses of vitamin C do contain high doses of oxalates also. That's why that patient. First thing they ask me, well, if you can use citrate, first thing they ask me, well, I take vitamin C to prevent cold and that. So, if you look at the ingredients, there's a high content of oxalates in that vitamin C. Yes.
How do you monitor when you pass a stone? Do you feed to a strainer?
Well, it depends. If the patient has time to do it, right, I tell them yes, go ahead and do it with a strainer. Most of the times, the stone is less than 7 millimeters and it's coming down and it's coming down. It tends to disintegrate. Some of them mostly heat sand. But I tell patients if you really want to know the composition of your stone, right? Yes, they start up with a strainer, right? And every time you pass through it, within that 10 to 14 days, right? See if you can get the stone. But I would say only about 20 to 30% of them usually catch the stone. Yes, some of them. I mean, the recurrent stone formals, they usually can show you their stones, right? Because they know when it's coming down, they know when they're going to pass it. Right? They could actually tell you, they stop it. They could tell you when they get to the pain, they'll stop the car, wait for a couple of hours, and then pass out the stone, and whatever, and then they come and show it. Right? And they pass stones like diameter 1 centimeter and more. Right? I mean, they're quite burst and pass.
Are there any other questions? Then we show appreciation. Our second speaker, Dr. Deo Singh, from the north, coming to the south, but he's been here before, so he's no stranger to us. He's going to talk on common ophthalmology conditions. Let us welcome Dr. Davis.
Thank you very much. Thank you all for having me. It's good to know I still have friends around in San Fernando, so I don't feel so much at a loss. So this is World Sight Day today, and so we should spend a couple of minutes talking about vision and preservation of vision and prevention of blindness. This is an analysis of 500 consecutive cases seen at Hercules Medical Sciences Complex, not my data, Dr. Morris' data, that was presented in 2012. And the next slide, 62% had cataract. Next slide, 11% had glaucoma. 24% had diabetic retinopathy, and of the diabetic retinopathy, 8% had proliferative retinopathy, and 20% had maculopathy. The maculopathy is a significant cause of visual impairment in non-proliferative disease. And so over 50% of those present, 500 people had moderate or severe visual impairment. So in that study, which ended last November, was a national study of eye diseases in which over 7,000 people were surveyed, indicated that uncorrected refractive error is the leading cause of moderate to severe visual impairment. So I just wanted to use that to talk a little bit about refractive errors and just to say that pay particular attention to kids because it impacts upon their education and their lives. And with correcting their refractive errors at an early stage, we can avoid them developing amblyopia. Amblyopia means that the vision, there's a disparity, a significant difference in refraction between the two eyes, such that the more affected eye does not develop normal vision. And particularly, that is important in the first 3 years of life. So let's move on to the retina. And just to say that every child should have some kind of an ocular assessment at birth, and it's simply observation. The eye looks funny, we need to know why. Is it crossed? One thing that we should all do is look at the red reflex. Look at the red reflex in pupil using the ophthalmoscope, and you will pick up if there's something significant in the posterior pupil, and look at the alignment of the eyes. Every child should have a preschool eye assessment. And maybe I'm thinking more and more now because I'm seeing a lot of teenagers, people in their 20s and 30s presenting with a short history. I only found out a few months ago I'm not seeing too well. And that condition could not have started 2 months ago. It started several years ago. So I'm thinking now if you tell people to walk around and do this from time to time so that they pick up the difference. People should be looking at kids and see whether they object to occluding one eye. Cover the eye. If they objected, it means maybe they are occluding the eye that they're really seeing better. If they are using any sort of preferential head posture in looking, if they're going close to the television, holding things close to their faces, it means that they are probably myopic and should be not scolded, they should have their eyes checked. So in the retina, the retina, we move on to diabetic eye disease. I know you guys see a lot of diabetes, it's so prevalent, and it's a significant cause of visual impairment. In this situation, we see the vasculopathy affecting the small vessels in the retina, which become leaky, causing edema and the macula, exudates of fatty material, and bleeding. Next slide. And then this will be represented by the ocular coherence tomography. This shows all the swelling, the cystic changes in the retina, and that will be associated with poor vision. that kind of picture might be associated on fluorescein angiography with widespread ischemic changes that indicate the need for treatment with the laser pan-retinal photocoagulation to prevent blindness. What you're doing here is destroying the ischemic areas which are producing vasoformative factors and therefore reducing or removing the stimulus for proliferation. Right, those are, and sometimes, of course, we see so often patients kind of late. You see, I think that as doctors, we tend to be too kind. We don't want to stress the patient out. We don't want to insist on them having their blood tests regularly and changing from one medication to another, and they get lax and they develop these things, and you can develop hemorrhages, pre-retinal and retinal hemorrhages, and so on. So diabetic eye disease is a big problem. I don't see a lot of it because I don't do retinal, but all my colleagues who do see a lot. The next common thing that you saw in some of the previous slides, the one from Mount Hope, the number of people that present to eye clinics with cataracts. Of course, we all know what cataract is, the opacification of the normally transparent crystalline lens. This kind of thing is a posterior subcapsular cataract, so it's in the visual axis, but near the posterior pole of the lens. And a small posterior subcapsular cataract, patient may sit in your consulting room and measure 20 centimeters. Now, I just want to make a point here. There's a difference between 20/20 quantity and quality. So when we report 20/20, we do really know what that means. When you hear the patient call the letters with some fluency, then you know that they have a good 20/20. For that patient, say 20/20 with a small posterior pole of cataract, when faced with glare like driving in the night, will be in a lot of trouble. When it's out in the sunshine, will be in problems. So next, then you have your usual nuclear sclerosis, which will get a clue on to a patient who has had who's been hyperopic, who's needed reading glasses, and as they go along, developing nuclear sclerosis, they become a myopic. We don't like to see this. This is a mature cataract, which can diagnose that from here to the corner. But we really prefer not to see that kind of thing today. There's no need for such late surgery in cataract. This is another mature cataract. And the standard method of cataract surgery is phacoemulsification. It's a small incision approach. In fact, I would say well over 95% of my surgery, I don't use any sutures. And the anesthetic approach, I have not been using injectable anesthetic for about 15 years. The procedure is a 20-minute procedure thereabouts. It uses a lot of technology, very predictable in most instances in terms of visual outcome because of the technology that we employ in calculating the strength of the intraocular lenses that we need. It doesn't address astigmatism, but there are special premium lenses at a cost that can be used to address that kind of thing. Of course, you will hear more and more now about laser-assisted cataract surgery, but I know that question is going to come up, so I'll save that for the end. Cataract surgery is not without its risks, right? And a lot goes in the management of cataract and in dealing with cataract surgery to contain risks, from action to the risk of risk to the cornea, protecting the cornea intraoperatively. I do a lot of cornea work, and I would say that probably 20% of my corneal transplants are for post-cataract corneal decompensation. So the preoperative assessment is very critical. Sometimes we are faced with an undiagnosed corneal endothelial dystrophy, which is aggravated by the rigors of surgery because you have a lot of turbulence in the anterior chamber. Fluid is flowing in, fluid is flowing out, and that can, and you do have some endothelial cell dropout that can lead to decompensation. Cataract surgery, so therefore, is essentially a refractive procedure nowadays. People want to know, well, you know, can I get 20/20 after? Can I read without glasses? And those are things that can be addressed. And this is an intraocular lens sitting very nicely in the posterior chamber behind the iris. These loops are within the capsular band. That's the kind of result that we want to see. And this is a diagrammatically. Okay, so the next big topic is glaucoma, and of course that has to do with the circulation of the aqueous in the front compartment of the eye, aqueous entering, being secreted by the ciliary processes into the posterior chamber, circulating, serving the function of a circulation fluid, bringing nutrients, taking away metabolites, metabolic waste from the front chamber. Remember that the cornea is not a vascular structure, so it has to get its nutrition either from the tear film, from the limbal vessels, or from the aqueous. So then it drains out to the trabecular network in the angle of the anterior chamber, and that balance between inflow and outflow is what will determine pressure. So we have all this classification of glaucoma, and the thing is that the visual field changes in early glaucoma tend to affect the nasal field, right? So the nasal field to my left eye is here, but I'm seeing this with my right eye. The nasal field to my right eye is here, but I can pick the left eye. So I don't appreciate these nasal visual field effects that occur early in diagnostics. And when I begin to figure out that I have some peripheral visual loss, it really is late in the day. By that time, we would have lost about 50% of our axons. All right, our retinal nerves, nerve fibers, we would have lost about 50% before we detect changes on a visual field assessment, and hence the development of other technologies. This is another type of glaucoma, acute angle closure glaucoma. We see a lot of chronic narrow angle glaucoma as well. And the only way we can detect that is by actually looking into the angle until now. But now the imaging technologies will give us a picture of the angle. This is what we would see in acute narrow angle glaucoma, in which the patient presents with acute pain, visual impairment of sudden onset, the eye is red, the cornea is steamy. If you shine a light, you don't get a crisp, like if you shine your pharmaceutical light on the cornea, you don't get a crisp reflex. The pain might be severe, and the patient might have systemic symptoms like nausea, and that is an emergency. If we're going to save vision, we need to deal with that immediately. So, this is what happens to the nerve. So, the first thing that we observe in detecting glaucoma in the course of an examination is what is the appearance of the optic nerve. And you can see the normal optic cup in a longitudinal section here, and if you look straight in with the ophthalmoscope, this is what it looks like. And as it progresses, that cup is deeper excavation and eventually becomes quite a crater. And one of the things that we notice is that when you look here, you can see the pits in the cribriform plane to which the nerve fibers are exiting. So the optic cup is enlarging. And usually we say if the cup to disc diameter is greater than 0.3, we need to be concerned about glaucoma. It's not just the dimension, it's the contours. In other words, this picture here gives you the impression that the blood vessels are disappearing below the lip of the cup, and then they re-emerge as they cross. So, a note on ocular pressure. Pressure alone does not make the diagnosis. The most significant clinical observation is the appearance of the optic. Then the eye pressure. Because you see, there's a group of people who are labeled as normal tension glaucoma subjects. In other words, the pressure is measured within the normal 10 to 20 range. They may have circulatory insufficiency to the optic nerve. They may have thin corneas. Because when we are measuring pressure, we are making a direct measurement by indenting the cornea and transcribing the force that is required to indent a fixed area of cornea into an intraocular pressure. As opposed to if you go to the service station and you're going to measure the pressure in the car tire, the point at which the pressure is recorded, there's a direct communication between the inside the tire and the measuring tube by pressing that pin. So in thin corneas, you tend to get a falsely lower reading. In thick corneas, you tend to get a falsely higher reading. So we also measure corneal oximetry in assessing that. This is that halo that people tend to talk about in people who have symptoms of narrow angle. Right, so we use imaging, we use visual field. This here is the optical coherence tomography analysis of the nerve fiber layer around the optic nerve, and it measures the thickness of the nerve fiber layer, throws it on this kind of a graph, and what we see here is that this is a normal reading, and this here, it dips into the red zone for most of it, so these are low. So we follow progressively. Remember, if we take a snapshot now, it doesn't tell us anything. We need to repeat these readings as we go along as part of the monitoring process to determine whether we are doing well with the treatment. So when we see a patient, depending on what is the state of the optic nerve, what is the visual field, what is the pressure, the time of diagnosis will guide us as to what kind of pressure target we want to set. And then we reassess and we see, well, you know, we went from 25 to 18, but we're still having some kind of a loss, although the rate of loss might have been retarded. So perhaps we should aim for a pressure under 15. Right? So I want to touch on allergic disease because this is something common that we all see. Everybody sees allergic disease, and it's a big problem. We use this to springboard into a corneal condition that is almost, I would say epidemic, but it's not really epidemic because that's my life is cornea. So this is a guy who this guy is in his mid-30s, and he's had allergic eye disease from the time he was a kid. So they present with the usual symptoms. Sometimes the kids are just blink a lot, or the eyes, then runny eyes, itchy eyes, they tend to rub the eyes a lot. And that is associated with other allergic manifestations, asthma, atopy, and whatever. But you really want to encourage them or discourage them from rubbing the eyes, because that kind of scenario is significantly associated with keratoconus. And this is the picture that we all think about when we think of keratoconus as medical students. Patient looking down and see the indentation of the lower lid by this conically shaped cornea. That can become so deformed that spectacle lenses are of no use. Contact lenses don't sit properly, and then they go on to develop scarring of the cornea, and they need to have a corneal transplant. So sometimes you need simple methods, avoidance of the allergens, use of cold compresses. Sometimes in mild cases you can simply use ocular lubricants. There are a lot of them out and very economical, I understand. Artificial tears, antihistamine drops, vasoconstrictors. Sometimes you need to use systemic antihistamines because of other situations and so on. Some we need to use topical steroids. But a caution here, topical steroids, because this is a recurrent thing and they get relief, they will tend to go to the pharmacy and keep on it chronically. Because you can get anything without a prescription. So a cautionary note is that long-term topical steroids like systemic prednisolone and so on is associated with cataract formation. But also topical steroid has a higher risk for glaucoma than systemic steroid. And if we're not monitoring them, we may end up with a difficult situation. The early diagnosis, you see, it's my feeling is that in today's context, every kid whose refraction is changing, that they're increasing in astigmatism or myopia, especially the abscess of astigmatism, is that they should be screened for keratoconus. And we have the tool. I mean, we've been doing corneal topographies for about 15 years or so now. The problem is if they go to the optometrist to get their spectacle, they go, it changes, it will change. They get a new prescription and so on and so on. And then they're growing up. They're in secondary school preparing for CXCs, so they're busy, they don't have time. They get treated with contact lenses. The next thing is skin, they don't have time. They get treated with no contact lenses. And then they present when they have to put their life on hold for a year while they have the corneal transplant and so on and so on. So the thing is that we should diagnose and treat early. And I have several kids, about 5 of them, who are 10 years old, a couple are 12 years old, 15 years old. As long as we see signs of progression, depending on the degree of deformity of the cornea, we will proceed to corneal cross-linking. Corneal cross-linking is something we've been doing for about 8 years now in Trinidad. And what it does, it increases the number of chemical bonds between the layers of the collagen in the cornea. And simply what we do is we saturate the cornea with riboflavin, special preparation of riboflavin, and then we expose the cornea to a low dose of UV light. The technique we use now is 10 minutes, and that's it. It's a one-off treatment. It prevents it reduces the risk, I should say, because I've had over the last 8 years to retreat about three people. Another approach is the use of intrastromal corneal rings. These are called intacs. They tend to reshape the cornea and make it less irregular in shape, and so improves the quality of vision. They will still need spectacle correction or contact lens correction. The contact lens technology has improved over the years. Sorry, and this shows a patient who has had intacs minus 4.75 plus 5.25. That's the degree of astigmatism. Doctor 275, doctor of astigmatism. When they get to the point like this, we need to do a corneal transplant. So if we could prevent the progression, then we reduce the rate of corneal transplants from keratoconus. I would say that 60% of the people whom I do corneal transplants on are for keratoconus. Now this kind of thing, we can't do anything but do a corneal transplant. Now a corneal transplant, this is a full thickness graft. And in today's context, we can do an anterior lamellar graft. In other words, what we do here is we replace the superficial 90% of the corneal thickness. I can tell you that when I'm in the operating room, I can actually visually appreciate what I'm left with when I dissect the anterior or the external 90% of the cornea, because what I left with is probably about 10 microns of tissue. The thing is that if we get them early enough before they scar significantly, we can try to do an anterior lamellar keratoplasty, and that the benefit of that is that it virtually eliminates rejection reactions. Thank you very much.
The floor is open to questions.
Site testing schools. That is reflected. Site testing. Any information on the percentage of children involved, how many of them have site problems?
The problem with that is that they used to like just testing in school age 5 years. The testing is not really perfect, and therefore many times we get children who are actually 20/20 and who are referred that they have decreased vision. So if we're not screening properly, we get the overall. So you can't really say a lot of them that we get really don't have. If you do the screening like how we did it in the clinic the other day, the Lions was doing it. They were sending me children from people with 2014, 2016, and they can't read 2029. But there's a lot of people around, a lot of noise, unless you can take a child and sit down and nice and quiet, pay attention to what I'm saying, and encourage them. Then you're going to get false guidance. But it's better to get them.
I don't know that we really have that statistic. Sorry, you.
We have clinical scenario recently with the patient with a stent, having had escalation and the patient actually had eye surgery recently. Are there any contraindications to giving thrombolytic therapy in terms of having the eye surgery? Because it could be a medical legal issue. Save the patient, but the patient ends up blind. So, do you know any?
Well, I mean, empirically, I would think saving the patient life takes precedence. But if you talk about cataract surgery, I don't stop my patients from taking their anticoagulants, whether it's what do you put them on, coumarin or aspirin or whatever. I don't stop them. I mean, for the cataract surgery because my incisions are corneal. I don't give injections, so I'm not at any risk of hemorrhages.
Right, so cataract surgery more.
Sure.
Sometimes fitness for anybody who wants cataract surgery, you want medical clearance. And I'm not,
Yeah. Okay, so when we're going to do cataract surgery, we need the patient recumbent for about at least 20 minutes, 25 minutes. We usually put a drape over their face. Some people give oxygen, some people don't. I don't. I've never seen any disadvantage to it. But however, if I have a patient who has had a cardiovascular event, I wouldn't cover the noses. So we want to know that kind of thing. What is their cardiovascular status? Can they lie comfortably? Any medications that you think now? Now, I say that I don't stop the anticoagulants, but some people do. So we want guidance from the physician as to their medical treatment. If they have any respiratory problems, you might know more about, for example, their drug reactions, because we will give them generally things like acetazolamide, and we will need to give them some kind of analgesic afterwards. Usually we give them one dose of analgesic, probably Ponstan or whatever. So that kind of thing we want to know. If they're on steroids, then we might want to know that we have to give them a intravenous shot around the time of surgery and things like that.
Well, things like hypertension, diabetes, things like that.
Sure.
Controllable things.
Sure.
I thought that is what.
Yeah, those are. That's the other thing, because those are. Well, I don't think it will matter. Stop it. If you've had them on it, it will affect the pupillary dilatation. We'll have a floppy iris anyway, so stopping it will make a difference. I don't know why you put me on the same panel as the urologist. I know we have 2 eyes, 2 kidneys, and 2 stones, but I mean, apart from that, the man has given us pressure with all his flow marks.
Thank you very much, sir. I won't say we've saved the best for last. I'll say they've all been excellent speakers so far. But our third speaker is Dr. Anil Kumar, consultant orthopedic surgeon at Mongo, and he's going to talk on osteoarthritis. Dr. Kumar.
So we talked about some salient features about osteoarthritis today. Next one. So these are the presentation tables today. Also, what is the arthritis? What's the economic impact? The types of arthritis, and we'll talk about some features of having cartilage, osteoarthritis, classification of osteoarthritis, the true features, causes, and also the treatment. As you all know, the arthro means joint and itis inflammation. So it's the inflammation of the tissues in the joint, usually resulting in pain, swelling, and stiffness. So, of course, I do not have the statistics from China. So it's arthritis of arthritis and musculoskeletal condition for nearly 15% of all health care. So it's a 315 million physicians here, taking the hospitalizations, 1.5 billion days of district activity per year. So we can see the okay. So number one most common reason for doctor visits, and second most common reason for hospitalization, and number 4 most common reason for surgery for arthritis. So, and also you can see as we living longer, so we're getting more and more prevalence of arthritis. It's almost 57% increase in last 30 years from 1990 to 2020. So it's going to continue to increase the prevalence of arthritis and the incidence of arthritis. So what is osteoarthritis? Osteoarthritis is a disease process affecting the synovial joints that is characterized by focal areas of articular cartilage, loss associated with hypertrophy of the bone, and thickening of the synovial capsule. So what I want you to know about what osteoarthritis not just affects the cartilage, it affects almost all tissues in and around the joint. That is the most important thing. And you can see the distribution of arthritis. Osteoarthritis most commonly affected by the weight-bearing joints in the lower limbs as well as the spine. You can see the knee is the most common, okay, and as well as the joints spare or the rest, and you have carpopharyngeal elbow and ankle. So the weight-bearing joints are the most commonly affected joints of the osteoarthritis. And this is a picture you can see the cartilage in the joint, the normal joint cartilage, that's the hyaline cartilage, and also arthritic joint cartilage. Here you can see that the cartilage in the normal joint is very much it's a very extremely smooth and its surface with no irregularities and very shiny the tissue. And you can see the arthritic cartilage, you can see focal areas of degradation, exposure of the subchondral bone, and as well as a lot of osteocyte formation, and as well as the synovial hypertrophy. And again, osteoarthritis is also called degenerative joint disease, which affects the entire joint, as I mentioned earlier, cartilage, ligaments, synovial, bone, and muscles. And about 60% of people over 65 have some form of arthritis with some joint in the body. So usually this is corresponds to the age, that means anybody who is 70 years or old, 70% of us will have 70% of the time will have osteoarthritis. If you're 80 years old, 80% of us will have osteoarthritis. So quality of life and increased mortality. So this is a microscopic picture of the normal hyaline cartilage in a light micrograph, and you can see it has different layers. And next one. And this is the schematic diagram of the hyaline cartilage. Is a ocular surface, and you can see the superficial zone, and which accounts for 10 to 20% of the superficial zone, and that is the most important part of the zone. And middle zone, and deep zone, and classified as subcontinental zone. So you can also see this side of the picture indicates the chondrocytes, and this side indicates the matrix. So you can see the superficial zone, the chondrocytes are arranged in a more parallel surface, and as you go down to the bone surface is arranged in a more vertical manner. Similarly with the collagen structure. And the most important thing, the superficial zone, which provides resistance against the shear forces. So that's the main reason the collagen is organized in a more parallel to the surface. And as it goes more deep to the bone surface, it provides more compression force. Means so that's the arrangement of the collagen. And normal cartilage is as the cornea, as you said about the cornea, is avascular, very lymphatic, and linear tissue. And it's smooth and resilient, allows shear and compressive forces to be dissipated uniformly across the joint. So chondrocytes are responsible for metabolism of the extracellular matrix and depend on diffusion from the nucleus. Therefore, the thickness of the cartilage is limited. So you cannot have too thick cartilage, you cannot have too thin cartilage. So because of the nutrition. So if you have too thick cartilage, you cannot get enough nutrition, so you have a degradation of the cartilage. And the extracellular matrix is highly hydrated combination of protein glycans and non-collagenous proteins, and is mainly made up of type 2 collagen. And pathology of osteoarthritis primary lesions in the cartilage. That's the difference between the osteoarthritis and rheumatoid arthritis. In rheumatoid arthritis, the primary pathology is in the synovium. And it leads to inflammation of the synovium and changes in subchondral bone, ligaments, capsules, and periarticular structures and muscles. So again, this is the arthroscopic view of the hyaline cartilages. You can see normal cartilage and meniscus, and the femur, tibia, meniscus, and this is the normal cartilage. So when you look at the normal cartilage in the arthroscopic, and when you probe it, it's almost like, feels like a glass, touching a glass with the probe. So it's firm and very smooth. And this is our scopic classification of cartilage injury. Again, it's a grade 1, it becomes soft. So that's the first grade of cartilage damage. You can see the characteristics the probe sinks into the cartilage surface. And the grade 2, you can see the start getting fissure or partial thickness defect, superficial fissure. You see. And grade 3, fissure into the level of subchondral bone. That is, the subchondral bone is not exposed yet, but it is the depth of the fissure will go from superficial zone all the way to the subchondral bone. So again, these fibrillations, associated fibrillations, flap layer, and flaking. And again, this is microscopic picture of the cartilage histology picture. You can see the fissure and fibrillation going all the way from superficial zone to the almost the subchondral bone. So this is one of the picture. And this is grade 4, exposed subchondral bone, because it's very long. And of course, this is where once the subchondral bone is exposed, the giant fluid leaks into the subchondral bone, causing the subchondral cysts and bone erosion. So these are the advanced stages of osteoarthritis. So these are the radiography of the joints, especially the knee joint. As you can see the normal cartilage space. So that means the wider the space, better it is. That means we have a thicker cartilage, and that cartilage space you can see the osteoarthritis is completely narrowing, and almost like bone touching and complete narrowing of the joint space. And in this we can see a lot of, as I mentioned earlier, the hypertrophy of the bone, and that indicates the osteophytes. You can see here, here, here. So, especially when a patient comes to the general practitioners, when you see a patient like this, no need to send the patient for MRI, because MRI is not necessarily diagnose the osteoarthritis. So this is just enough to diagnose the osteoarthritis or advanced disease. So when you do the MRI on a patient with this type of osteoarthritis, means of course all the MRI findings, what they describe on the report, is all you can find even without the MRI. It's associated changes which happen, so which is not, MRI is not necessary to diagnose. And this is the osteoarthritis of the hip joint. You can see the normal head with the normal cartilage space, and normal head. And here you can see a lot of subchondral cysts I was talking about, both on the femoral side as well as the acetabular side, and almost non-existent joint space. So what are the causes of osteoarthritis? The primary, is age, and secondary is post-traumatic. So post-traumatic may be the fractures, ligament injuries, sports-related injuries. So all that will then fall into the post-traumatic osteoarthritis. And endocrine, and of course acromegaly, hypothyroidism, all this will affect the metabolism of the cartilage. Of course, the next one is obesity. Then inflammatory joint disease, of course, once the rheumatoid arthritis starts in the synovium, eventually it affects the cartilage. So rheumatoid arthritis eventually leading on to osteoarthritis. An infection, gout, all this damages the cartilage, congenital, developmental, metabolic, neuropathic, and especially the diabetic patients here, and genetic and collateral diseases. So this is one of the X-rays of one of the patients which I followed for quite a long time. This is when he was 10 years old, and this is 18 years old, and now he's 30 years old. You can see this one of the examples of osteoarthritis. So when you come to treatment of osteoarthritis, most of osteoarthritis therapy are to decrease pain and maintain improved joint function. So there is no validated way to regrow the lost cartilage. So still we do not have any reliable way to grow the cartilage yet. So osteoarthritis, so what we're trying to do is to break the cycle of pain. So osteoarthritis, we have pain, then avoidance of joint motion, then going for stiffness, muscle weakness, and loss of motion, again that leads to pain. So we need to break the cycle. So that's the main aim of the treatment in osteoarthritis. So treatment of osteoarthritis: exercise, weight reduction and control, acetaminophen, NSAIDs, oxygen inhibitors, topical treatment, hyaluronic acid injections, antidepressants. So we'll go through some of the treatment options. And heart and core compressions. So most of the patient has when you're going to put heat, and also when you're going to hold. So if the patient has minimal no swelling with osteoarthritis, you can try to use the heat. If the patient has swelling, a lot of swelling, of course that means it is inflamed, exaggeration of the pain and swelling, we use cold compression. And if the patient has a lot of stiffness, then using heat. And joint protection devices, integrated therapy, steroid injections, narcotics, and of course, surgery. So exercise, as we all know, the modest reduction in pain and low impact aerobic exercises, strengthening, stretching and flexibility exercises, hydrotherapy, because it provides low impact exercises, and muscles are, as you know, they are strongly muscles around any joints in the body. These are shock absorbers, so less stress and strain on the joint. So obesity. This is the especially now it has become very in teenagers. So this is we trying to evolve the next generation of disease, obesity in humans. So it's an independent and modified risk factor. So obesity has, when it comes to osteoarthritis, not just the mechanical load, but it also has a lot of chemical damage to the cartilage. So weight loss will prevent osteoarthritis. So there are studies that show that it is going to prevent osteoarthritis. So these are the why the obesity is so important causing osteoarthritis. Just in mechanical load, it's also because of the chemical damage to the cartilage. As we all know, the leukocyte is one of the largest endocrine organ in the body, producing a lot of these hormones. So a lot of these hormones, like as you know, they produces chronic inflammation in the body. So we are going to the so this is some of the musculoskeletal effects of those chronic inflammation produced by the hormones in the obesity. So musculoskeletal system targets over cartilage, subchondral bone, meniscus, synovial cells, synovial fluid, tendons, fascial muscles. So all this leads to the degradation of the cartilage, subchondral bone degradation, soft tissue inflammation. So this is how the obesity affects the osteoarthritis in the, especially weight-bearing joints, not just the mechanical load, but it's also the chemical damage secondary to obesity. Then treatment again raises soft tissue sleeve increase the pain with warmth and compression. As you know, most of the patients will tell you that they feel more pain. So basically it increases the temperature in the joint, so it provides some relief. Some of the braces are unloading braces, and of course cane or walker just to unload the joint. So these are temporary measures for the osteoarthritis. Then oral supplements, glucosamine chondroitin sulfate. So this is the one. None of this will make cartilage to grow back, so but they may improve your pain and function. So this is one of the every time you see the advertisement on the television, you know they afraid they bring back the cartilage. So absolutely not going to grow back the cartilage. Then glucosamine chondroitin, as I know, it's a glucosamine glycan. It's a substrate for the glucosamine sulfate is a substrate for chondroitin sulfate. So you don't. There are several preparations in the market that have both glucosamine and chondroitin sulfate. So if you take just glucosamine, that is just enough. The glucosamine is a substrate where the chondroitin sulfate can be synthesized from. So negatively affiliated because affinity for waters, because it retains water in the cartilage. Increased age, it is decreased in this of glucosamine. Decreased extracellular matrix and loss of water and decreased resistance for load. These are some of the metabolic tolerability is only 26%. Chondroitin sulfate, 0 to 8% absorption of bioavailability is 0. And as I said, it basically acts like anti-inflammatory, decrease joint pain, tenderness, swelling, and improved range of motion, just like any anti-inflammatory medications. Almost all short-term studies and follow-ups side effects compared to other drugs. We don't know what's the long-term effects, and also we don't know the exact the dosage. I think currently most of the dosage is available as a 1,500 milligram tablets. And currently, Arthritis Foundation does not support the glucosamine and chondroitin sulfate for the treatment of osteoarthritis. And next option, the cortisone injections, injectable therapy, cortisone steroids are almost the same. So pain relief within several days to 3 months typical relief, and also depends on the severity of the arthritis. How long the pain relief will get, and helps to 2 of every 3 patients with osteoarthritis. It also has side effects. Frequent injections may increase, accelerate the arthritis and cartilage breakdown. So that's one of the problems the steroid injections, and will increase, of course, patients who have diabetes have close to 2-3 days patients with diabetes. Then I think we start with the CME injections. It's a hyaluronic acid injection. Then CME is a polysaccharide and secreted by type B sinusoids. Provides viscosity and elasticity of the synovial fluid, and also it is an analgesic and anti-inflammatory. And it reduces the prostaglandins, which is one of the mediators of the inflammation, and also decreases phagocytosis. So hyaluronic acid provides pseudoplastic properties, shock absorber, and lubricant and viscose supplementation. And what happens in osteoarthritis? There's decreased production of hyaluronic acid, and of course also because of dilution, because of the increased effusion in the joint. So this is classified as a medical device, not a drug, and currently FDA approved for all stages of only for knee osteoarthritis. Again, because it's not it's used as a medical device, right? So overall, the literature can be the publication bias, as highlighted in the systemic reviews, and according to American Academy of Orthopedic Surgeons, they say in guidelines 2015, we cannot recommend using of hyaluronic acid for patients with symptomatic osteoarthritis. Again, these days patients are asking for this, the platelet-rich plasma. So even this one, we do not have a long-term studies, and you can see the other purely as a benefit. The augmentation of tissue healing, evidence-based literature suggests that the success depends upon the preparation method, medical condition of the patient, anatomic location, tissue type, and further clinical studies are required for, especially for the to recommend whether it is recommended or not in osteoarthritis or other conditions. So, in terms of surgeries, arthroscopic lavage and debridement, drilling and microfracture, arthroplasty, limb alignment procedures, and of course the arthroplasty. So, from the arthroscopic debridement, mainly for short-term relief, and especially for patients who have the acute onset, who have a mechanical problem, especially if you have a large fragment of cartilage causing the mechanical problem, meniscal fragments. So those are the patients who will benefit from arthroscopic lavage, and so those are the patients who are, especially patients who have normal extremity alignment, and of course the radiographic evidence of minimal radiographic evidence. So here is one of the patient with acute microfracture treatment. You can see the loss of full thickness loss of cartilage and microfracture. and then bleeding, and then eventually we form some cartilage. But the cartilage which forms here it's not a hyaline cartilage, it's a fibro cartilage. So the quality of the fibro cartilage do not withstand the normal stresses of the joint. So it's not going to last for long. So that's going to be a problem with the fibro cartilage. Yeah. And fibroplasty techniques provide unpredictable results and durability for fibrocartilage repair tissue and thermal damage while drilling. And recent long-term studies have demonstrated that outcomes after fibroplasty were no better than placebo. And of course, the controls. These are some of the patients we recommend limb alignment procedures like high tibial osteotomy in patients who have varus or valgus deformities. So when they do the limb alignment procedures, prevent rapid progression of osteoarthritis. So indicated for physiological young and active moderate deformation with mild osteoarthritis is normal ligament structure. This is one of the picture of the high tibial osteotomy. You can see by doing osteotomy, you shift the weight bearing of the from the affected side to the non-affected side. So that's the main advantage of high tibial osteotomy. So you can buy more time for probably later on for the knee replacement, knee replacement or unicondylar knee replacement. And then unicompartmental arthroplasty, of course, this has its own indication. And this is one of the treatment options for the osteoarthritis. And then next, the total joint arthroplasty for tricompartmental advanced osteoarthritis. Next one. And again, this is next picture of the knee replacement of the patient. And this is a hip replacement with the same patient which I showed you before, and the severe osteoarthritis with the hip replacement as one of the surgical options to the treatment of hip osteoarthritis. So this is the presently available algorithm for treatment of osteoarthritis. So starting with the physical therapy, NSAIDs, if it is helpful, so home exercise program, then you can try the physical, that is hyaluronic acid injection or corticosteroid injection. It's helpful, again, home exercise program, and if it is no, then so you look at if the patient needs any mechanical problem, if the patient has any mechanical problem, you can go knee arthroscopy, meniscal debridement. Or if the patient has a limb malalignment, then you can go for high tibial osteotomy. So then if you have a unicompartmental osteoarthritis, go for unicompartmental arthroplasty. Of course, last one is the totally arthroplasty.
Any questions?
Dr. Mark, can you please make comments about these centers in cartilage? Yes. Yeah, that's what I mentioned. The FDA has approved Synvisc injection hyaluronic acid for all grades of osteoarthritis, specifically for the knee. So you can use it for mild, moderate, severe osteoarthritis. But most of with my experience, most of the patients who have mild and moderate osteoarthritis benefit a lot. How effective? It is quite effective. I've seen patients, quite a number of patients with mild, moderate osteoarthritis. They come and take probably like once a year, 3 injections. 1 injection 1 week apart. Every week? Yeah, every week, one injection every week for 3 weeks, 3 injections. Yeah, it's quite effective. I've seen patients who especially mild moderate osteoarthritis, and patients who have a normal limb alignment. If the patients have a valgus or varus limb deformity, knee deformity, they don't benefit much. Yes.
You comment on use of omega-3 fatty acids in the use of arthritis?
As far as I know, there's anti-inflammatory medications. As I said, there are no medication which can build back the cartilage. Definitely, it will help you with the pain.
Help with pain?
Yes. Omega-3 is basically anti-inflammatory medication. Yeah. Yes.
We now call on Dr. Arthur to give the stand.
Hi, good night everyone. And first of all, let me just say thanks to everyone for enduring with us and for being part of this meeting tonight, our October meeting. I'd like to thank our speakers who are all really in the middle of the applause, please. And we'd like to show them our appreciation. Dr. Black, can you please come? We're going to ask Dr. Crystal Superman to come and give you a token of our appreciation. Next, we're going and then we're going to ask Dr. Dean to come, please. And we're asking Dr. Sarah Ramjet to come and give him his token of appreciation. And we'll also like to thank him and Dr. Johnson for coming and attending one of our outreach programs this past weekend in California. They assisted in the screening of over 150 people. So we thank them both. And Dr. Kumar, we're going to ask Dr. Anderson to come. Thank you very much. We'd also like to thank our sponsors this evening, IC Ophthalmics and AMA. Thank you very much. We need your support. We'd like to thank the staff of Factor Palace for providing us with a dinner that was well balanced. I like balance. And I'd also like to say thanks to Dr. George Shambi for chairing our meeting this evening, and to Dr. Bishi Bihari for planning this wonderful meeting for us. Just a few quick reminders, please. Your feedback forms which are on your table, you need to fill them out and hand them in at the back so that you'll be able to get your credits for this. Credits are awarded to those members who have signed on with TTME. So if you're not a TTME member, we encourage you to please make sure you fill out one of our membership forms and you join us. So we're encouraging you to come and be a part of this wonderful association. Our annual general meeting will be next month, that is in November month. So we're encouraging you to come on, take part, learn a little bit more about our organization. We had a wonderful outreach program over the weekend. It was in Garconda, and that was Sunday. Like I said before, they saw over 150 individuals, and we'd just like to give our team and the doctors that attended a big round of applause. Tonight's meeting is the first meeting that we were able to stream live over the internet, via the internet, and we would like to thank Eden for coming and assisting us so that those at home could also join in with us if they're not able to be here in person. And of course, we thank you, the attendees, for being here tonight. So once again, thank you all very much. Get home safely.